Hello everyone. Today we are going to learn about psychiatric emergencies. So first we need to learn what is emergency, right? Before going to psychiatric emergency, we should know what is emergency. So emergency is nothing but an unforeseen combination of circumstances which calls for immediate action. That is called emergency. Right? And there are two types of emergency. One is medical emergency and another one is psychiatric emergency. So what is medical emergency? Medical emergency is called as medical condition in which endangers life or cause great suffering to the individual. That is called medical emergency. Now we will be seeing what is psychiatric emergency. So psychiatric emergency is a condition wherein the patient has disturbance of thought, affect and psychomotor activity leading to threat to his existence or threat to the people in the environment. And this condition needs immediate intervention to safeguard the life of the patient, bring down the anxiety of the family members and enhance emotional security to others in the environment. And this condition, in which there is alteration in behaviors, emotions or thoughts presenting in an acute form in need of immediate attention or care. So what are the common psychiatric emergencies? Is suicidal threat, violent or aggressive behavior or excitement, panic attacks, catatonic stupor, hysterical attacks and transient situational disturbances. Before moving towards all the emergencies in details, we must know what are the characteristics of psychiatric emergency. So there are three characteristics. First one is any condition, situation making the patient and relatives to seek immediate treatment. Second one is disharmony between subject and environment. And third one will be sudden disorganization in personality which affects the socio-occupational functioning. Now for these characteristics, what will be the objectives? What are the objectives for psychiatric intervention? Is first to safeguard the life of the patient, to bring down the anxiety of family members and to enhance emotional security of others in the environment. Right? Then what are the general guidelines to manage psychiatric emergency? There are a few guidelines. So I'm going to tell you one by one. Handle with the utmost of tact and speech so that well-being of other patients is not affected. It means you should speak slowly, act in a calm and coordinated manner to prevent others from getting anxious. Shift the time as early as possible to the room where they can be safeguarded against injury. Ensure that all other clients are reassured and the routine activities proceed normally. And psychiatric emergencies overlap medical emergencies, and staff should be familiar with the management of both. So these were the few guidelines to manage psychiatric emergencies. Now we are going to see one by one. Suicidal tendencies, suicidal threat, which is also called a deliberate self-harm, right? So how we are going to manage that? One of the commonest psychiatric emergency, this is commonest cause of death among psychiatric patients, right? In psychiatry, a suicidal attempt is considered to be one of the commonest emergency suicide. Is type of deliberate of self-harm and is defined as an intentional harm act of oneself. Now what are the epidemiology. What is the epidemiology? So, one among the 10 cause of death because of suicidal tendencies, suicide rate in India is 10 population. Male to female ratio is 64 to 36, and highest in the group of 15 to 29 years of people. What are the methods used for suicide is ingestion of poison, hanging, burning, drawing, and jumping in front of the train or vehicle. Now we will be seeing etiology. For the etiology, there are drugs or dementia, then second down financial and occupational difficulties. So these are the etiology of psychiatric emergency. Now, that to age group and sex, male are above 40 years of age and female sex, men have greater risk of completed suicide. Suicide is more common in men, as I told you earlier in epidemiology, and women have higher rate of attempt to suicide, married, divorced, widowed, or separated. Risk factors in psychiatric ward, like in certain psychiatric disorder where the patient may develop suicidal tendencies, which comes under major depression, schizophrenia, mania, drug or alcohol abuse, personality disorder, and organic conditions. So let's see one by one. In major depression, like this is the one of the commonest condition associated with high risk of suicide. Suicide in a major depressive disorder is due to pervasive and persistent sadness, pessimistic cognition concerning the past, present, and future, delusion of guilt, helplessness, hopelessness, and worthlessness, and derogatory voice urging him to take his life. The risk of suicide is more when the acute phase has passed and the characteristics of psychomotor retardation has improved. This is so because the patient has more energy to carry out his suicidal plans now, though he might have been harboring them for quite some time. So this was about major depression. Now let's talk about schizophrenia. In the major risk factor among schizophrenics include the presence of associated depression, young age, and high level of premorbid functioning, especially during college time. People in this risk group are more likely to realize the devastating significance of their illness more than other group of schizophrenic patients do, and see suicide as reasonable alternatives. In mania, many patients may occasionally commit suicide. This is usually the result of grandiose ideation. The patient may believe that he is a great person or wish to improve his supernatural powers. With this intent in mind, he may carry out some dangerous activity that can cost him his life. Next, we will be seeing drug or alcohol abuse. In that, suicide among alcoholics can be due to depression and withdrawal phase. Also, the loss of friends and family, self-respect, status, and general realization of the havoc alcohol has created in his life can cause the individual to wish to die. In personality disorder, individuals with historic or borderline traits may occasionally attempt suicide, and in organic conditions such as delirium and dementia due to change of mood like anxiety and depression may also induce suicidal tendencies. Now let's see management. What are the management is available? Be aware of certain signs which may indicate that the individual may commit suicide, such as suicidal threat, writing farewell letters, giving away treasure articles, making a will, closing bank account, appealing peaceful or happy after period of depression, refusing to eat or drink, maintain personal hygiene. So in this case, we should be careful. Then next one is monitoring a patient's safety and needs. In that it includes take all the suicidal threats or attempts seriously and notify psychiatrist. Search for toxic agents such as drug or alcohol. Do not leave the drug tray with reach of the patient. Make sure that the daily medication is swallowed. Remove sharp instruments such as razor, blade, knives, glass bottles from his environment, and remove staples and clothing such as belt and necessities. Do not allow the patient to bolt his door on the side from inside. Make sure that somebody accompanies him to the bathroom. Patient should be kept in constant observation and should never be left alone. Have good vigilance, especially during morning hours. Spend time with him, talk to him, and allow him to ventilate his feelings. Then you should encourage him to talk about his suicidal plans and methods. If suicidal tendencies are very severe, sedation should be given to the patient, and encourage verbal communication of suicidal ideas as well as his or her fear and depressive thoughts. No suicidal pact may be signed, which is a written agreement between the client and the nurse, and the client will not act on suicidal impulses but will approach the nurse to talk about them. And at last, you should enhance self-esteem of the patient by focusing on his strengths rather than weaknesses. His positive qualities should be emphasized with realistic praises and appreciation, and this fosters a sense of self-worth and enable him to take control of his life situation. So this were about suicidal tendencies. Now we are moving towards the violent or aggressive behavior or excitement. So this is the severe form of aggressiveness. During this stage, patient will be irrational, uncooperative, delusional, and assertive. What are the etiology? Is organic psychiatric disorder like delirium, dementia, mimic Wordsworth psychosis, and other psychiatric disorders like schizophrenia, mania, agitated depression, withdrawal from alcohol and drugs, epilepsy, acute stress, reaction, panic disorder, and personality disorder. So these are the etiological factors. Now, what are the do and don'ts in violent or aggressive behavior patient? So protect yourself, unharm the patient, keep the doors open, keep other near you, do restrain if necessary, assert authority, and show concern, establish rapport, and assure the patient. Now, what are the don'ts? You don't need to do anything. Do not keep potential weapons near the patient. Do not sit with back to the patient. Do not wear neck, tie, or jewelry. Do not keep any provocative family members in the room. Do not confront, and do not sit close to the patient. So these are the few things you need to keep it in mind. What are the management of violent and aggressive patient tied up? That reassurance, firm and kind approach is essential. Ask direct and concise questions. Avoid yes or no questions. Assist the patient in defining the problems. In sedation, diazepam 5 to 10 mg, slowly IV we can give, haloperidol 2 to 10 mg, IV IM, and chlorpromazine 50 to 100 mg, IV or IM we can give. Now collect all the details, history, and explore the cause. Carry out complete physical examination. Check hydration status. If severe dehydration, IV fluids, Have less furniture in the room. Remove all sharp instruments, as we talked about it earlier. Keep environmental stimuli to the minimum. Stay with the patient to reduce anxiety. Redirect violent behavior with physical outlets such as exercise, outdoor activities. Encourage the patient to talk out the aggressive feelings rather than acting them out. And physical restraint, use as a last resort. We are not supposed to physically restrain the patient. Then it should be done in human way. Take written consent from caregivers, which is very important, and get a second opinion if possible. Then guidelines, approach patient from the front. Never see potentially violent patient alone. Have a 4-member team to hold each extremity. It means 2 hands and 2 legs. Keep talking while restraining. Do not leave the unattended after restraining. Observe every 15 minutes for any numbness, tingling, or cyanosis in the extremities. Ensure that nutritional and elimination needs are met. So these are the few things we need to keep it in mind, and the management of aggressive and violent patient. Then there are few guidelines of self-protection while handling the aggressive patient, which is never see the patient alone. Keep a comfortable distance away from the patient. Be prepared to move. Maintain a clear exit route. Be sure that the patient has no weapon with him. If patient is having a weapon, ask him to keep it down rather than fighting with him. Keep something, pillow, mattress, or blanket between you and weapon. Distract the patient to remove the weapon, example, throwing water on the face, and give prescribed antipsychotics. Next, we are going to see the panic attack. What is panic attack? Panic attack is an episode of acute anxiety and panic occur as a part of psychotic or neurotic illness. What are the clinical manifestations? Palpitation, sweating will be there, tremors, feeling of choking, chest pain, nausea, abdominal distress, fear of dying, paresthesia, and hot flushes. So these are the clinical manifestations will be present in panic attack. What are the management for panic attack? Is give reassurance, search for the causes. What is the cause of the panic attack? Injection diazepam 10 mg or lorazepam 2 mg given. Counsel the patient and relatives and use behavior modification technique. Next is stupor catatonic syndrome. Stupor is a clinical syndrome of agnosis and mutism, but with relative preservation of conscious awareness, often associated with catatonic signs and symptoms. What is catatonic syndrome? Any disorder in which presence with the at least 2 catatonic signs. Catatonia is either excited or withdrawn, and catatonic sign is negativism, mutism, stupor, ambitendency, echolalia, echopraxia, catalepsy, stereotypes, verbigration, excitement, and impulsiveness. Now, what are the management we do to manage catatonic stupor? Is ensure patient airway, maintain hydration, trials tube for feeding or IV fluids, check vital signs regularly, history and physical examination should be done, draw blood for investigation before straining any treatment, identify the specific cause and treatment, provide care for an unconscious patient, care of skin, nutrition, elimination, and personal hygiene is required. And other care as we do for an unconscious patient. Next one is hysterical attacks. Hysteric may mimic abnormality of any function which is under voluntary control. The common modes of presentations may be hysterical fits, hysterical ataxia, and hysterical paraplegia. All presentations are marked by dramatic qualities and sadness of mood. What are the management we can give for hysterical attack? Is hysterical fits must be distinguished from genuine fits. As hysterical symptoms can cause panic among relatives, explain to the relatives the psychological nature of symptoms, reassure that no harm would come to the patient, and help the patient to realize the meaning of symptoms and help him to find the alternative way of coping with the stress. And suggestion therapy with IV patothal may be helpful in some cases. And the last one is transient situational disturbances. So these are characterized by disturbed feelings and behavior occurring due to overwhelming external stimuli. Right? In that management, reassurance we can give, mild sedation if necessary, allowing the patient to ventilate, and counseling mild and understanding professional. So today we have learned about psychiatric emergencies, which are common psychiatric emergencies: suicidal threat, violent or aggressive behavior or excitement, panic attack, catatonic stupor, hysterical attack, and transient situational disturbances. So here we are concluding our topic, psychiatric emergencies. So in emergency psychiatry is the clinical application of psychiatry in emergency setting. Conditions requiring psychiatric interventions may include attempted suicide, substance abuse, depression, psychosis, violence, or other rapid changes in the behavior. Thank you.